Good morning, good afternoon, and good evening, philosophers, and welcome to episode 10 of Philosophy of Science Through the Lens of Medicine. You are not the average patient. Statistically, almost nobody is. An awkward start for a medical system built around averages. Suppose a randomized trial finds that a new drug reduces migraine days by 2 per month, on average. But what will it do to your migraines? Reduce them by 10, do nothing, move a brass band into your skull? The trial can't observe both timelines in which you take the drug and yet don't take it at the same time. But your doctor must recommend one treatment to one person right now. Welcome to the dispute between evidence-based medicine and patient-centered care. Evidence-based medicine, or EBM, integrates the best available research with clinical expertise when treating an individual patient. For treatment effects, it gives a special weight to randomized trials and systematic reviews. Patient-centered care, or PCC, as we discussed in the last video, begins with the patient as a person, their experience, circumstances, goals, and values. Decisions should be made with patients, not merely delivered to them. So EBM starts with, what does the best research show? PCC starts with, what matters to this person? EBM arose for an excellent reason. Authority, biological plausibility, and personal experience can all mislead. A patient may improve because an illness fluctuates, another treatment helped, or they would have recovered anyway. Clinicians also remember dramatic successes more readily than quiet failures. Human memory is not a systematic review, it is a highlights reel edited by an unreliable producer. Random allocation helps separate a treatment's effect from confounding at the group level. Systematic reviews reduce the temptation to select only the study that agrees with us, and guidelines can protect patients from wildly inconsistent practice. The motivation is epistemic and ethical. If a treatment costs money or risks harm, I have a good feeling about it shouldn't be enough. Patients deserve care that has survived more than the charisma of Professor Famous. But advocates of patient-centered care raise three important objections. First, applicability. Bensing argues that EBM can become disease-oriented and fill the doctor's agenda with population evidence, while the person before them may differ from trial participants. Trials often enroll selected patients under controlled conditions. You may be older, have several illnesses, or live in circumstances the trial never represented. Even if you resemble the trial sample, an average effect is still an average. Some participants benefit greatly, some slightly, some not at all, and some may be harmed. Randomization can give us credible group comparison, but not a crystal ball for individuals. The result really might not represent how you will respond. Second, trials measure selected outcomes. Researchers may count tumor shrinkage or months of survival. A patient may care most about pain, fatigue, sexual function, or collecting a child from school. If that outcome was never measured, placing the study higher on a pyramid doesn't put it back in. Third, evidence can't determine values. Treatment A might offer longer life with severe fatigue. Treatment B, perhaps less time but more independence. Evidence estimates the likely consequences, but it can't decide which trade-offs matter and which make a life go better for the individual. That's not a missing confidence interval, it's a value judgment. Now, the EBM reply is, okay, objection accepted, but you're addressing it to the wrong version of EBM. David Sackett explicitly denied that EBM was cookbook medicine. External evidence informs expertise, it doesn't replace it. His account includes the patient's predicament, rights, and preferences. On that definition, the clinician must ask whether the research applies to this patient and how it should be used. EBM can also individualize. Consider baseline risk, credible subgroup effects, pragmatic trials, patient-reported outcomes, and sometimes an N of 1 trial where one patient systematically compares treatments. These tools narrow the gap, but they don't abolish it. No method can guarantee how this individual will respond. Patient-centered care needs an answer too. Preference can't establish that a treatment works. A respectful conversation about an ineffective drug leaves us with an ineffective drug. Now with excellent communication. Without reliable information about benefits and harms, patient-centered care risks becoming polite guesswork. So, is the whole debate misguided? Well, perhaps partly. Hoffman, Montori, and Almar argue that EBM and shared decision-making are interdependent. Patient-centered care identifies the question, outcomes, and options that matter. EBM constrains the menu to options with credible evidence of benefits and harm. Both sides risk caricature. Patient-centered care advocates attack EBM as obedience to a pyramid. EBM defenders treat patient-centered care as giving patients whatever they request. But neither is the strongest opposing view. But the dispute is not imaginary. Sackett's ideal includes the patient, real-world guidelines, targets, and overfilled consultations can still squeeze the patient out. What should we do when the population evidence is strong, but its fit to this person is uncertain? If the evidence says best on average, and an informed patient says not best for me, who should have the final say? Choose your corner, defend it, and please don't punch a straw man. Thanks for watching, please like and subscribe, and I'll see you on the next one.